Welcome to this presentation of the GAP, MASLD, and MASH Community Network, sponsored by Madrigal Pharmaceuticals. My name is Scott Springer. I'm a PA working in Buffalo, New York at Erie County Medical Center. I work in a hospital-based outpatient hepatology clinic, treating pretty much all stages of acute and chronic liver disease. You can use this QR code to record your attendance for this meeting. And today what we're going to do is we're going to discuss, a patient case comparing, a similar patient with F3 and F4 fibrosis, and the difference between those when it comes to management and surveillance and things of that nature. So this, like I said, this case is split up into two parts. 6A, we have Sam. Sam is a 55-year-old male. He was referred to us for mildly abnormal transaminase levels and an abdominal sonogram with increased liver echogenicity. He complains of fatigue. Some demographic info, like we said, he's 55 years old. He is Caucasian. His BMI is 33 kilograms per meter squared. Some of his medical history includes type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, and denies history of alcohol use. On a review of his med list, he has lisinopril, rosuvastatin, ezetimibe, and dapagliflozin. On our physical exam, we note that he has an obese abdomen. There are no apparent stigmata of advanced liver disease and no hepatosplenomegaly on abdominal exam. Some of the lab results we have here include an ALT and AST. Both are mildly elevated. The ALT is 85 units per liter, AST 72 units per liter. Alkaline phosphatase is within normal limits. Total bilirubin is at the upper end of normal, but still within normal limits. Platelets are at the lower end of normal, but again, still within normal limits. Hemoglobin A1C is 7.1%. Look at his vitals. Again, we see his BMI. Other vital signs are relatively unremarkable. And then further labs looking at his creatinine 1.1, INR 1.0. We note his ferritin is elevated, 780, but his iron saturation is 30%, and that's within normal range. So he's not iron overloaded. Of note, he does have a positive ANA with a 1 to 80 titer, but smooth muscle antibody is negative, and viral hepatitis serologies are also negative. So essentially the picture here is mild aminotransferase elevations, some ferritin elevation, and a positive ANA of unclear significance. Okay, so we have our lab tests, but now we want to get into some non-invasive testing for assessing liver fibrosis. So we know in any patient with chronic liver disease, there's always a risk of developing fibrosis due to the chronic inflammation, and we use non-invasive testing modalities to assess this. So the first thing we can look at, because we already have these lab values to calculate it, is a FIB-4 score. When we calculate his FIB-4 score, we get a 3.1, which falls into an intermediate risk category, which is 1.45 to 3.25. So just below the high risk category. If we look at a different serologic test that doesn't appear to be done initially, we can order something called an ELF test, enhanced liver fibrosis test, which will kind of help us estimate the risk of advanced fibrosis and liver disease. When we do an ELF test on this patient, we get a score of 9.9, and being it's greater than 9.8, that's regarded as severe, but not quite cirrhotic, based off of the ELF scoring. Then in the middle, those two bars are FibroScan testing. So FibroScan is transient elastography on an ultrasound machine. What we get is two scores out of a FibroScan. We get a liver stiffness measurement, which is in units of kilopascals. And for this patient, he had a liver stiffness measurement of 11 kilopascals, which is consistent with significant fibrosis or F3 fibrosis. And then there's a CAP score. CAP score is related to the amount of fat in the liver. So this score was 262, which is consistent with moderate steatosis, kind of on the borderline of severe steatosis. So looking at these three different non-invasive testing modalities, we certainly have risk for moderate to potentially severe disease. This correlates with the increased echogenicity we saw on the abdominal ultrasound, that there truly is a good amount of fat in the liver. And also we have concern for significant fibrosis, F3 fibrosis, based off of these testing results. So questions they pose for us here. Is there any further testing you'd like to perform on this patient? And how would you stage this patient? So the first part, I think while there is low clinical suspicion for autoimmune, hepatic process in this patient, an isolated elevated ANA is most often not clinically significant and not correlated with any real, active disease process. I would, in this patient, order some additional autoantibody testing and likely a serum IgG level just to more definitively rule out an autoimmune hepatitis. That's really the only testing I think that would be appropriate for this patient. Additionally, at this time, because the non-invasive testing results were pretty in line with each other. Sometimes when we do multiple non-invasive testing, um, modalities on patients, the results are kind of discordant, where one suggests low risk for advanced disease, another one suggests, wow, this patient may have cirrhosis. And in those situations, there's some diagnostic uncertainty, but I don't think that's really the case here. And I think the lab values that we saw, again, are consistent with that. Platelets, he's not thrombocytopenic, which would potentially correlate with clinically significant portal hypertension. His total bilirubin is not elevated. So the picture fits. And I think we can confidently stage this patient as an F3 fibrotic patient based off of the FibroScan testing. So the next questions are, how would you treat this patient and how would you monitor this patient? So this slide starts touching upon those things. The list that they have here is start resmetirom, lifestyle modifications, consider a GLP-1, monitor for HCC. So my take on this is, while I do think resmetirom is appropriate for this patient, I think the most important thing when it comes to management of a patient like this is really aggressive management of the cardiometabolic risk factors. So this patient has type 2 diabetes, his A1C is above 7. So I think that GLP-1 is a good idea because we know that GLP-1s can also help with body mass reduction, which is a really important piece of hepatic steatosis, MASLD, and MASH management. And one thing we know is that for patients with MASLD or MASH, the majority of them will die from, adverse cardiac events, not from their liver disease. Certainly, the liver disease is something important for us to manage, but these patients, the MASLD or the MASH really is just a hepatic manifestation of a larger metabolic syndrome. So I think aggressively treating the metabolic syndrome with lifestyle modifications, medication adjustments to treat the type 2 diabetes, the hypertension, dyslipidemia, those are all really important things to do. Then because he does have advanced fibrosis, F3 fibrosis, based off our non-invasive testing, he is an appropriate patient to get started on resmetirom. So I think that's another thing that we do for this patient. And then potentially we're going to monitor for HCC. So hepatocellular carcinoma, if you're not familiar, is a type of liver cancer that patients with cirrhosis are at increased risk of developing. Okay. So based off of our staging, it doesn't appear that this patient is yet cirrhotic, but certainly we are seeing some patients, even though they have advanced fibrosis that's considered to be pre-cirrhotic, they still can develop HCC. So that's something that we're seeing. Guidelines don't explicitly state, routine interval screening for HCC in patients with pre-cirrhotic fibrosis, but that is something in clinical practice that we are doing. So now we're going to kind of go to the part B of this case study. So it's the same patient in a number of ways, as far as history and BMI and demographics, physical exam, right? But there are some differences here. So we note significantly here that the platelet count, 128,000, is a bit lower than the case 6A. Everything else appears similar, but the ANA is 1 to 80. I think it was 1 to 40 previously. So unclear significance that part, but I do think that the platelet count being lower, possibly thrombocytopenic, depending on what values you're using, or likely thrombocytopenic for most values. And then total bilirubin is also pushing up too on that upper limit of normal. So these are concerning for more advanced disease. Now we get into the NIT scores. What do we find here? So these are the same three assessments that we used on the first part. However, now our FIB4 is suggesting a 3.11. Where it really differentiates, so that they're still in the intermediate risk category, but the other two assessments, the ELF serologic test and then the FibroScan, the elastography, do paint a more concerning picture, okay? So the ELF, we get a score of 11.4, which is consistent with truly advanced disease and potentially cirrhosis. And then our FibroScan liver stiffness measurement, we have a score of 21 kilopascals, which is absolutely consistent with a level of fibrosis that meets criteria for cirrhosis. So we certainly have concern for more advanced fibrosis in this patient case, and actually the development of cirrhosis. Is there any further testing you'd like to perform on this patient? There may be some argument to say that the FIB4 suggested an intermediate risk, and the FibroScan being that it suggested F4, there's some discordance there. So I think potentially there is room for a liver biopsy to more concretely establish the level of fibrosis, because that can change the management of this patient. If this patient truly is cirrhotic, they wouldn't qualify for an antifibrotic medication like resmetirom. But if they were F3 and the FibroScan overestimated the amount of fibrosis, they would potentially be missing out on that therapy option. So that's one thing to consider. Additionally, again, the elevated ANA, while our clinical suspicion is low, if you're trying to cover all your bases, I think it is not a bad idea to more concretely rule out autoimmune hepatitis with additional autoantibody and IgG testing. How will we stage this patient? I think at this point, based off the changes in the labs and the liver stiffness measurement, that we would characterize this patient as cirrhotic until proven otherwise. So next questions, like the last case, how would you treat this patient and how would you monitor them? So kind of similar to before, the diet and lifestyle modification is of paramount importance in a patient with cirrhosis, certainly a patient with cirrhosis due to MASH, okay? It's very likely those cardiometabolic risk factors that, led to the development of this chronic liver disease and the cirrhosis are still present, and optimizing those and effectively managing those is going to do a lot for this patient and their outcome. Now that the patient is, strongly believed to be cirrhotic, HCC surveillance is really important. So what does the interval look like for screening? In patients that you're just diagnosing with cirrhosis, you want to get a liver ultrasound to look for focal hepatic lesions that could be suggestive of hepatoma. And you can also order a serum AFP level, which is a biomarker we use in screening for HCC. So we want to do that at least every 6 months. In patients that have indeterminate lesions on ultrasound, It's generally recommended that you do cross-sectional imaging, ideally contrast-enhanced cross-sectional imaging, like a CT or an MRI, for better characterization of the hepatic lesion. But again, that's at least every 6 months. Okay. And then lastly, for patients with cirrhosis, um, some but not all patients should be screened for esophageal varices with an EGD. So Vino 7 criteria kind of helps us gain understanding of evaluating whether a patient has clinically significant portal hypertension, utilizing a liver stiffness measurement like our FibroScan and a platelet count. So based off of this patient's liver stiffness measurement that's over 20, platelets less than 150,000, this patient certainly does have clinically significant portal hypertension based off of that assessment, and they are at risk for developing varices. So if endoscopy is readily available, certainly recommend a variceal screening EGD. Another consideration is getting this patient on a non-selective beta blocker, specifically carvedilol, which can help reduce the development of decompensating events in a patient like this. So just looking at the patients side by side, 6A and 6B, the FIB-4 scores are the same, but you see in 6B, the ELF score and the liver stiffness measurement are both elevated relative to 6A. One thing you'll note is that that we didn't mention yet is the CAP score, which is correlated with fat content in the liver, is lower in the 6B case. One way that we can think about this, and it's far from definitive and proven in this case, but as the liver becomes more fibrotic, uniformly fibrotic, um, the fat that was there in hepatocytes is turning to scar tissue, right? So the fat is that was previously detected, and in case 6A, as the fibrosis develops, the fibrosis takes place of those healthy, or not necessarily healthy, but functioning fat-laden hepatocytes. So that sometimes we can see with the progression of disease as patients become more fibrotic. The fat kind of goes away just because the tissue is being replaced by scar tissue. So that's possibly what we're seeing here. Discussion. So how do these two patients compare in management? We kind of discussed this. I think when you're talking about management of patients who are borderline F3, F4, we would recommend treating them as if they're cirrhotic and managing them as if they're cirrhotic. But when it comes to MASH, it makes a big difference whether or not we can use resmetirom in these patients. Because if we can, we certainly want to increase the likelihood that we can get the fat and scar tissue out of their liver. So essentially, we want to treat the patient as if they're cirrhotic, do HCC surveillance every 6 months. Similar goals of optimizing cardiometabolic health with pharmacotherapy and lifestyle modification. And yeah, I think that the main difference is whether or not the patient qualifies for resmetirom or not. So when we're staging between F3 and F4, which non-invasive tests do you most typically use to differentiate between the two? We talked about indeterminate NITs a bit earlier. So NIT, again, is non-invasive tests. In my practice, we have a FibroScan in our institution, so that's what we use most often. That being said, we are always doing a FIB-4 because CBC and a CMP are part of our initial workup. And oftentimes we will order an ELF test just for correlation purposes, especially if the FIB-4 and the FibroScan are discordant or indeterminate, which we often will see. So all three of those tests are what we use regularly in practice. And ideally, the results of all of them are consistent enough that we don't have to proceed to a biopsy. Most of our patients don't get biopsies, but sometimes it is necessary when there really is significant clinical uncertainty with what's going on. And when is HCC surveillance important? I think you want to consider HCC surveillance every 6 months in patients that are on the borderline of F3 to F4, and absolutely in patients who are believed to be cirrhotic. It's of paramount importance. You have to do it until the patient dies. It's something that you do every 6 months, and that's something you tell patients up front. We're concerned you have cirrhosis. One of the things we're going to do going forward is you're going to get a liver scan every 6 months. That's just to ensure that you're not developing cancer in the liver. And the important thing is we do the surveillance. If something is developing, we catch it early and we can manage it in the least invasive way possible. So that's why HEC surveillance is so important. For further disease state education on MASLD and MASH, you can scan this barcode to be brought to the GAP MASLD and MASH Community Network, where there's plenty of educational material and promotional material for Rezdiffra from Madrigal, who sponsored this program. Any questions and answers? I'll be happy to answer any questions that you can send to me through the community network and my page on there. And feel free to contact me. I'm happy to chat. And that's all. So thanks for watching. And like I said, please reach out if any questions, and have a good night.